Ladies and gentlemen.
This episode is sponsored by Advanced Skills Company, the official agent of JPI Healthcare in Iraq. I personally use the products of JPI Healthcare in my clinic for years now, and throughout the years, these products have been amazing in terms of providing excellent image quality at the lowest radiation dose possible, and they are durable, reliable, and efficient. I recommend if you are looking to establish your radiology practice, whether in a clinic, in a center, or in a hospital setting, to go to the JPI Healthcare website, see their products for yourself, and then call Advanced Skills Company if you are in Iraq, and these guys will provide the best possible solutions, whether in terms of hardware or software. I will leave the contact information in the video description, and don't forget to use the magic word highlights in radiology, because you will get a 10% discount on all JPI Healthcare products till the end of 2024. Hello everyone, and welcome to a new episode of Highlights in Radiology. In today's episode, we are going to talk about the common cause of ankle pain, and that is os trigonum. Before we start, I want to remind you to subscribe, like, share, and tell your friends about us. This is Dr. Ahmed Dia Abdul Wahab, and this is Highlights in Radiology Season 2. Stay with me. Os trigonum syndrome, also known as talar compression syndrome or posterior ankle impingement syndrome, is defined as pain with disruption of the cartilaginous synchondrosis between the os trigonum and the lateral tubercle of the posterior talar process. This syndrome is seen most commonly in females with pain syndrome seen at 20 to 35 years of age. The symptoms are frequently relieved with rest, and it might progress to flexor hallucis longus tenosing tenosynovitis. The most common presentation is with posterior ankle pain, also tenderness and soft tissue swelling. The pain is exaggerated by plantar flexion and weight-bearing activity. Also, decreased range of motion can be seen. It is seen in 0.2% of ankle sprain population, and in 50% it's bilateral. The os trigonum pain is present in about 10% of the population. So what radiology can offer in this condition? Plain radiographs will show os trigonum bone with smooth edges and dense cortical bone. It appears usually well-defined, round, with a prominent os trigonum or trigonum process. Sometimes we might see a irregular gap between the talus and the os trigonum on the lateral views. On MRI, on T1 weighted imaging, we will see os trigonum that appears enlarged, containing fatty marrow. Also, we will see a hypointense degenerative sclerosis or cystic changes between the os trigonum and the talus. Also, hypointense sclerosis or edema in a trigonal process. Like for example, in this T1 weighted MRI image, you can see the os trigonum appears prominent, enlarged, with fatty marrow, and you can see the synchondrosis having some hypointense signal, which might be due to sclerosis or edema. Another example, you can see the os trigonum appears enlarged, well-defined, fatty marrow with some sclerosis with the posterior talar process. Again, another example, T1 weighted image, you can see the area of sclerosis at the posterior aspect of the talus or the posterior talar process. On T2 weighted images, the os trigonum or the trigonal process will appear hyperintense. Also, we will see hyperintensity on the posterior aspect of the talus with edema or synovitis posterior to the talus and superior to the os trigonum. Sometimes we see isolated hyperintense tenosynovitis in the flexor hallucis longus tendon sheath. For example, in this T2 weighted fat saturated image, you can see the os trigonum and surrounding soft tissue edema suggesting tenosynovitis with some bone marrow edema at its junction with the posterior talar process. Another example here, you can see the os trigonum that appears edematous with some surrounding edema. Even intra-articular loose bodies can be seen. The size of the os trigonum can vary from absence of the os trigonum to grossly enlarged. There are 4 types of os trigonum. Type 1 is just a normal tubercle, while type 2 is an enlarged tubercle, also known as STIDA process. Type 3 will be seen as an accessory bone, or what we call the ostrigonum. And finally, type 4, there will be fused ostrigonum by synchondrosis or syndosmosis with the talus. Treatment is usually conservative by splinting, anti-inflammatory agents, and steroid injections. Surgical treatment includes resection of the ostrigonum and the surrounding fibrotic tissue. Complications include arthritis and impingement of the soft tissues. What's the differential diagnosis of this condition? We have a good list here, including fracture of the lateral tubercle, also known as shepherd's fracture, posterior soft tissue impingement, flexor hallucis longus tenosynovitis, dancer's foot, and flexor hallucis longus chair-kind deformity. In the shepherd's fracture, there will be irregular jagged separation between talar body and the bony fragment. There will be progressive widening of the fracture site. Like we see here in this X-ray, you can see the fractured fragment with separation from the talar bone. Another example, in this CT scan, we can see the posterior talar fracture or the shepherd's fracture with the fractured fragment jagged ending and separated from the talar bone. Regarding the posterior soft tissue impingement, it will happen on the posterolateral side of the ankle joint, involving the posterior and transverse tibiofibular ligaments. Prolonged impingement will result in fibrosis, capsulitis, and synovial swelling. Like for example, in this T2 weighted image, you can see there is prominent edema, there is a prominent posterior talar process, and you can see there is synovial swelling and joint effusion. Another example here, you can see posteriorly there is posterior soft tissue impingement with findings of edema and swelling and possible tenosynovitis. Flexor hallucis longus tenosynovitis will result in fluid in the tendon sheath with scar formation and fibrosis in chronic overuse injury. Like we can see here in this T2 weighted fat saturated image, you can see the tendon of the flexor hallucis longus showing fluid accumulation surrounding the tendon in the tendon sheath. In dancer's foot, there will be subchondral sclerosis of the posterior facet and calcaneocuboid joint. Like we can see here in this X-ray, this is the shape or the position that the dancer's foot is suffering from, and you can see the calcaneocuboid joint and the posterior facet are sclerosed. There is subchondral sclerosis at these regions. T1 weighted sagittal image of the ankle joint in the dancer's foot, you can see the calcaneocuboid sclerosis, and the posterior facet is showing some kind of sclerosis due to chronic overuse. In the flexor hallucis longus chair-kind deformity, there will be fixed tethering of the flexor hallucis longus at or proximal to the flexor retinaculum, causing flexure contraction of the interpharyngeal joint of the hallux or the big toe and claw hallux. It's usually seen in post-traumatic adhesions with healing of the distal fractures. If you see here on this X-ray, obviously there is a fracture that's healing, and this will result in thickening of the retinaculum, causing entrapment of the flexor hallucis longus tendon. Again, another example, in this X-ray, you can see the healing of the fracture will cause the pathology. So this was all for today's episode. Don't forget to subscribe, like, share, and tell your friends about us. If you have any comments, write them in the comment section. See you next Friday at 5 p.m. This is Dr. Ahmed Abdul Wahab, and this is Highlights in Radiology Season 2. Bye.